dry skin that they found out of all of those questions were if you had a paternal age that was older, you were more likely to have dry skin. If you were more than 38 weeks estimated gestational age, so for some reason, earlier gestational age actually was less likely to have dry skin, which I thought was very interesting. And also, if you have a cat, you're less likely to have dry skin later on, which I also thought was interesting. They looked at transepidermal water loss, and there the only things that they found was that being born in the winter season or maternal allergic disease was the association, and you were less likely to have it if you were a girl. And then actual eczema itself, the only associations they found were maternal allergic disease, multiparity, and C-sections, which is an interesting question in terms of possibly the microbiome. Then they looked at the babies at 3 months of age, and they tried to determine whether having dry skin at 3 months of age was going to be a predictor for having eczema at 6 months of age. And this is an interesting way to present it, but what they found is they looked at 11 different areas on the baby, and if they found any evidence of dry skin, they would fall within the dry skin group. 52 kids didn't have any progression to AD. These are the ones that did progress to atopic dermatitis, and you can see there's overlap if you have different areas that are involved, but having dry cheek skin was found to be associated with development of AD. So if you see a baby at 3 months of age who has dry skin anywhere, but especially dry cheek skin, that baby's at risk for developing AD. So why that's an interesting question is, would there be any benefit to moisturizing infants to try to prevent them from developing atopic dermatitis? I think it's a really important question. There was a pilot study done a few years ago that showed that potentially there would be a benefit if you start moisturizing infants from a very young age. They would be less likely potentially to develop atopic dermatitis. This study actually looks directly at that question. This is a follow-up from that pilot study where they used daily moisturizer during infancy to try to prevent eczema. This was the BEEP randomized controlled study. And it was a pretty large study. You can see, do you guys see my arrow when I do that? Yeah, you do. Okay. There was a bunch of families that were identified. Some didn't want to participate. They ended up with 1,500 families. And then they had 1,400 that were randomly assigned. And they were assigned to either the moisturizing group or the non-moisturizing group. And basically both groups were told about how to do dry skin care and how to take care of the baby, and they all got the same education. But the intervention group actually was instructed on how to apply the moisturizer specifically, and then they were given moisturizer for the whole year until follow-up. So the one intervention was that they would get the moisturizer and asked to have it applied, and they would keep getting it for the first year of life. And they were told to apply the moisturizer at least once a day, but also every time the baby was bathed. So it's a pretty rigorous and pretty good study. And what's interesting is it didn't make a difference. And so that's a bit frustrating from that standpoint, because it'd be really a wonderful thing to be able to advise people to do. But if you look, the groups here are completely identical. They actually even looked at mutations, and the results are across the board. There was no difference, unfortunately, in the development of atopic dermatitis with the use of moisturizer starting at a young age until the first year of life. And this is just a graphic representation of the EASY score and the parental evaluation of eczema, and there really wasn't a difference with moisturizer. That was also, this is the study that I told you the other one was coming off of. This is actually the PREVENT ADL study, and I'm probably saying it wrong because I wasn't involved in these studies, but this was the group that looked at it in Oslo. And so the initial group that was looking at dry skin was the group that did not get the intervention. This was another big study. There was 2,400 newborns that were randomized to 4 different groups. There was a no intervention group. There was a skin emollient, very similar to what we did. But they also looked at whether early complementary feeding of peanut, cow's milk, wheat, or egg at 12 to 14 weeks, which is pretty early introduction of food, would make a difference in terms of the development of atopic dermatitis. And then they had a group that had both the skin and the food intervention. So the previous study that I mentioned to you was the ones that were not getting the skin intervention. And unfortunately, this was also a negative study, which thank goodness it's being published, because we want to see negative studies being published, but they found that neither skin emollients nor early complementary feeding was associated with prevention of atopic dermatitis. So bit of a bummer, but it's good that these negative studies are being published. So another question arises then, once you have a baby with atopic dermatitis, does it matter which hygiene products you use? And this picture here is showing, if you go to Amazon and you put in baby shampoo hypoallergenic, you get all these different choices in Amazon. And so if you're a new parent with atopic dermatitis, how do you figure out what you want to use or not use for your child for things like baby shampoo and soap? And this was in the JAD back in May. You may have seen it. This was looking specifically at whether these hypoallergenic baby products had cocamidobetaine in the products. And the reason why is because we know that patients that have atopic dermatitis will frequently be more likely to be sensitized and develop allergies to cocamidobetaine, and it's been suggested that maybe they shouldn't be exposed to it. And so this study looked at, just like I did at Amazon, it went to 6 different large retailers and put in the words baby shampoo, baby soap, and hypoallergenic, and it looked at what products came up. And what they found is that half of the shampoos and 44% of the soaps actually had the product, the cocamidobetaine in it, with Walmart having the most and Amazon having the least. And here is the graph, or sorry, the table showing you that all of these products, which we frequently will possibly recommend, or you'll see frequently, do have the cocamidobetaine in it. You'll see Cetaphil products, Eucerin, and Aquaphor, and very few of these products, which interestingly, the Honest Company is one of them, which it went through that whole scandal a while ago, but the Honest Company is one of the ones that had decent products, or products that didn't have the cocamidobetaine in it. And then California Baby, which is one that Dr. Matisse used to always recommend that I consider for my patients that have contact dermatitis. So the words hypoallergenic don't necessarily mean that you're gonna have less allergens in it. Okay, atopic dermatitis. What about tacrolimus? This is kind of old, right? We all know about the black box warning. We've all had to give that black box warning talk. And because of the black box warning, the Apple study was instituted. And the Apple study was a prospective study that was looking at long-term safety of patients who were under the age of 16 when they used tacrolimus for more than or equal to 6 weeks at some point. It's a pretty ambitious study. And you can see that it started off with 8,000 patients enrolled, and 7,954 were eligible. And then, as you would expect with a 10-year study, you had a lot of patients that were lost to follow up. However, taking the patients that completed the study and that completed it all the way to 10 years, they were trying to determine if there was an incidence of cancer that was higher. And specifically, the black box warning, I think, talks about lymphomas and possible skin cancer association. So you want to see if there was more of that. And what they found was that in that large group, there were 6 patients who did develop cancer. But if you look at the types of cancers that were developed, they're all over the board, and they're not necessarily all within the same category. And when you look at the total number of observed person years, the expected incidence of cancer was actually 6. And so it really is further proof that we don't need to worry about the risk of cancer with topical tacrolimus application in children. And this is a fantastic study that you can now more comfortably say that when you're having your discussions, your black box warning discussions with your patients. Okay, I only have, so genodermatoses, there's all kinds of things that I find that are fascinating, but I didn't want to go down a rabbit hole of things that you may not see as much in practice. And I'm actually only going to talk about one journal article for genodermatoses. And this is something that's been around for over decades, maybe more. I've only been in practice for 15. But this is through the American Academy of Pediatrics. They put out a updated health supervision for children with neurofibromatosis 1, and it's an excellent article. And I suggest that the dermatology residents actually look at it, especially when they're going through their genodermatoses sections and studying. This is meant to help physicians know what to look for and how to treat. And it's got all kinds of fantastic clinical pearls within it. And so it mentions, for example, that you're not going to see, that when you see cafe au laits and NF, they're usually present since infancy. So when you have the development of cafe au laits in a teenager, it's less likely to be neurofibromatosis. It talks about how even though you may not see Lish nodules till later on, you still want to get ophthalmology involved because there's that risk of optic gliomas. It's got a lot of really great information in it for the residents. It even has a differential diagnosis for patients with cafe au lait. So when you're going through and studying, it helps you figure out how to differentiate them. It's a great board review paper as well. What came out this time, which is new, is that they actually mentioned the nevus anemicus and JXG as being common findings in NF. And they went so far as to say that they do not suggest surveillance for leukemia in patients with NF who have JXG. That's always been sort of a controversial topic, but this actually said that there was not really great evidence for it. It also mentions, for example, that pruritus is really common in neurofibromatosis, and you may not be aware of that. And it actually doesn't really improve with the use of lotions or antihistamines, but in older patients, you can consider the use of gabapentin. It mentions that the number of cafe au laits does not necessarily predict the severity of NF, and that when a child comes to you, it's really not possible to predict the future neurofibroma burden that you're going to have. So it's an important thing to be aware of when you see a patient that doesn't look like they have very many cafe au laits, that you really can't say what kind of future involvement this poor child's going to have. And then, of course, it talks about flexiform neurofibromas, which if you see them and they're having any kind of pain or growth or neurologic dysfunction, you should really get imaging to make sure that it's not becoming malignant. It furthermore talks about development. So if you see a patient who has potential neurofibromatosis or has neurofibromatosis, make sure that they're getting their development evaluated. So the way I see this is important is frequently you'll have somebody referred to you for a few cafe au laits at a young age. And I think it's important to get them set up with genetics and ophthalmology and neurology, but also to mention that they need to make sure that that developmental aspect is being addressed very, very specifically. And specifically learning disability, speech therapy, those type of issues are questions that I'll ask, because sometimes people can be fluid with speech and say that speech comes later, but if you've got a patient who potentially has neurofibromatosis, you want to make sure that that's getting addressed. Young adults will have a higher incidence of breast cancer that they should be aware of as well, and then adolescents should be watchful for scoliosis. And I thought this was also interesting, is that they're also at higher risk for osteopenia and vitamin D insufficiency. So it's just a great review for neurofibromatosis if you're actually looking at your genodermatosis studying. And this is a nice evaluation of what you're supposed to get done whenever you're seeing the pediatrician, which is not going to be your responsibility. All right, moving on to vascular lesions. This was actually a series of 7 patients with a really characteristic vascular lesion. I thought this was a fascinating picture because I think I saw a patient with this when I was visiting CHOP one year. So this is a series of 7 patients with this distinct capillary malformation that has this central atrophy. And they did stains and found that it was GLUT1 negative and D240 negative and that it was not fitting into the other categories. And then they actually looked at the genes and saw that there were no mutations in GNAC, which as you can see with capillary malformations that have Sturge-Weber. And then they didn't have any mutations in GNA11, which can be seen with overgrowth syndrome with capillary malformations. And then they did an MRI to see how extensive these lesions were, and also look for any other associated malformations. And they found that they were all negative. So it's it's another vascular malformation that you can include into your differential diagnoses of vascular malformations. And it was reassuring that these did not have any other systemic involvement. Now going to a more common vascular malformation that you're more likely to see. When do you worry about a port wine stain on a patient's face, especially the upper face? So this, for example, is a patient that I saw in Dermatology just a few weeks ago who had a vascular stain on the eyelid. He was 10 months old, and they wanted to know whether they should be worried about it or not. And the reason why it comes up for the first years who may or may not be aware of this is that we used to actually think that Sturge-Weber syndrome was seen with the V1 distribution, and that this is the way you would think of what was going on. And this paper came out, I think it was 2014. The Welkley, I keep saying her name wrong, or the Welkley study that actually showed that actually the upper forehead from that area on was going to be associated with Sturge-Weber. And in their study, it had to be from the forehead on, because it's probably a placoid issue, like the hemangiomas are. And so anything on the forehead up would be more concerning for Sturge-Weber syndrome. This was another study that was looking at different patterns and said that this pattern and this pattern was more concerning for Sturge-Weber syndrome, and possibly this pattern could be as well. But this group out of Seattle looked at forehead location, but specifically looked at large segmental pattern of facial port wine stains to see if there was a risk for Sturge-Weber syndrome. And it was a retrospective chart review of 124 patients with port wine stains. 96 had port wine stains that were on the forehead, so that would be included in the previous study, but they divided them up into large segmental or trace or small segmental, and 45 patients had that. And of the entire group, 21 had Sturge-Weber syndrome. And here's a visual representation for what they would consider a large segmental, if it's in the middle here large segmental, large segmental. And here's some pictures of what that would mean. So this, for example, is a large segmental who did have Sturge-Weber syndrome. This one is a large segmental who did not. And this would be a small segmental, right? Because you're looking at above this eye line, and this patient did not have it either. And so what they found is, in comparison to the previous, just the upper forehead study that was done, all 21 of the patients would have been found in either group. But if you're looking at exclusion and the ones who did not have it, only 28 didn't have a forehead stain in the initial study, and in this study, 73 of the ones who didn't have a large segmental did not have it. So it showed a greater specificity. And then in terms of the patients that were included in their group, in terms of all forehead, that would have been 96 for the other study and only 51 for this one. And so your positive predictive value is better. And so this is showing that a large segmental port wine stain on the forehead is going to be a better indicator than just saying on the forehead at all. Okay, I'm quickly going to go through some other therapies that have come out or been discussed in the literature for pediatrics. This one, although it was first published in 2019, actually didn't get published in print until 2020. And this was looking at ivermectin safety in infants and children under 15 kilograms. If you've ever written for ivermectin, you know that it's indicated for children and adults over 15 kilograms. And this was looking at its use in scabies in children under 15 kilograms. It was a series of 170 patients, and the average dose was 223 micrograms per kilogram. And only 7 patients had side effects from it. And 5 of those were exacerbation of the eczema, which it's hard to say. And the one had vomiting and one had diarrhea, but none of them had significant side effects. And so it's showing the potential safety of the use of ivermectin in children under 15 kilograms. Another therapeutic study is this treatment of vascular anomalies with Serolimas. So I think I gave this talk a year or 2 ago, and we looked at lymphatic malformations and superficial lymphatic malformations treated with topical Serolimas, which can be really helpful. This is a group, a series of 18 patients from different centers, I think 8 different centers, that treated different vascular malformations, combined venous lymphatic and tufted angiomas, and showed that at least in 100% of patients, at least some showed improvement of one aspect of the troublesome aspects of their vascular stain. 50% reported marked improvement in at least one aspect. And then they did sampling for blood levels of Serolimus in half of the patients, and only 2 of them had systemic levels, which were not terribly significant, and one of them was applying it to a malformation on the tongue. So these are the different types of malformations and the improvement in the different things that they were looking at, whether it was bleeding, whether it was blebs, infection rate, induration or thickness, cosmesis, pain. And they had improvement. All the patients had at least improvement in one of these areas. This just shows the pictures of the improvement that you can see. So the topical Serolimus applied, significant benefit. Significant benefit. So it's something new in the armamentarium for these patients that may be having problematic lesions. The last therapeutic I'm going to mention, I was not involved in this study, but it's an interesting study because this is possibly something that will be coming out on the market soon. Dr. Eichenfield was the lead author on this study. This is looking at the safety and efficacy of a VP102 proprietary drug device to deliver cantharidin for the use of molluscum in children and adults, although there were very few adults in the study. There were 2 separate phase 3 randomized clinical trials, which CAMP 1 and CAMP 2. And this was really a pretty remarkable study because if you look at in terms of evidence in previous studies, it really hasn't been shown that necessarily cantharidin is helpful to really decrease the overall incidence or rapidity of resolution of molluscum, but this study actually did show that when it compared it to the vehicle. These are done 3 weeks apart, and you can see that you actually see a difference in terms of the patients who had complete clearance in both of the studies. And another representation shows this one you actually had an increase in the baseline lesion counts compared to a decrease when you were actually getting treatment. And so this is both interesting and great because you can see that this is something that potentially is going to be on the market that you can use or that possibly pediatricians will use, but it also shows that treatment actually makes a difference. Moving on to hemangiomas. So this patient comes into your office with obviously a segmental hemangioma, and you want to start therapy right away because you're getting distortion. but this patient doesn't have insurance and does not want to get an MRI right away because it's going to be thousands and thousands of dollars. So you want to start therapy for the patient, but there's some delay in possibly doing an evaluation for face syndrome. And the reason why this becomes a question is that there's been some thought that possibly patients with face are at a greater risk of stroke with propranolol because of their anatomic anomalies that they have. And so not doing that study could be potentially concerning. And this was addressed in JAMA Derm in February of this year, or partially addressed anyway, where there was a large group of 11 institutions where they took their face patients who were treated for propranolol and tried to see if there was any problems from it. And you can see in the group, 16% were categorized as high risk for stroke, 43 for intermediate risk, and 82 had an anomaly of the cervical or cerebral vessels. And so these are patients that you would potentially be concerned about. And they all were treated with propranolol, and there were no serious adverse events. Here you can see the events between 726 patients who did not have face syndrome that were treated with propranolol and 76 who did. So there's not a lot, it seems like there's only 76, but there's not a lot of patients with face. I think the registry only has about 300 patients right now. So 76 is a pretty good number. And they really found that there were no serious events, as you can see, as compared to just patients who got treated for their hemangioma without having face. There were actually a few serious events. And the main one that we're seeing, there was some gastrointestinal, but also sleep disturbance. So 17% of patients described sleep disturbance, and without face, it was only 7%, although I'm not sure if it was statistically significant or not. But basically, this study was showing that if you need to treat a patient who potentially could have face with propranolol, you don't necessarily need to delay the evaluation before being able to treat them if it's a hindrance for you starting the medication. They did make some recommendations that you should always do a physical exam and do an echocardiogram if possible to make sure that you can rule out aortic arch coarctation, and that you should start with the lowest dose possible. So you don't have to go for that 3 mg per kg. You can start with the lower dose and see if you can get some improvement. And in this situation, you could initiate 3 times a day dosing instead of twice a day dosing, which we tend to do as our norm. And then also that you should not use concomitant timolol. I mentioned in the previous talk that I gave a year or 2 ago that timolol can be absorbed, and larger surface areas in older children are more likely to actually have that absorption. So you're going to be getting more medicine than you think you are if you're doing timolol at the same time, and so they recommend not doing that in these situations. Going on to sleep issues. Sleep issues are one of the things that we talk about potentially being an issue with propranolol, but it could possibly be a side effect. And it's always been interesting to me in terms of whether or not I actually bring this up with the parents or not. And this is actually not a journal, but rather it was a presentation. It was a poster that was presented at our annual SPD meeting, virtual SPD meeting this year. And it actually got an award because I thought it was a great study myself as well, but it got an award for the poster presentation coming out of Zurich. And it was a sleep behavior during propranolol treatment of infantile hemangiomas, a prospective controlled study. And it was really well done. They had 45 patients that were treated for propranolol and 45 age-matched controls that were not. And what they did is they asked these questions. So the parents filled out a questionnaire. You know, how do you consider your child's sleep as a problem? How regular is the bedtime of your child? And all these questions. And they showed that the hemangiomas were responding to the use of propranolol, as you would expect, as you can see here. But then what they also did is they actually put a monitor on the baby's ankle with a sock and tried to determine how frequently the baby actually woke up. And they also asked the parents to keep a log. You're not going to understand this because I think this is German, but they asked the parents to say how frequently the baby woke up. And what's interesting, and what he commented on at the study, at the meeting, was that how frequently they woke up did not have any correlation with how well the parents thought the baby was sleeping. So I think a lot of it has to do with what you think your baby is supposed to be doing or how frequently babies should sleep. Because what they actually found was there was a variety with the objective sleep measures of actually having that monitor on the baby and seeing how much they actually woke up. There was actually no difference between the patients, either at 3 months or at 6 months. This is preliminary data. I think there's only 20 some in each group, but there really wasn't a difference in terms of what the sleep was, but rather possibly the perception that the baby's not sleeping well might be something that's going on, which makes me wonder whether we should be mentioning it as a potential side effect, whether we're actually putting that into the parents' head a little bit when we say that. Okay, just a few more things to go through really quickly. Acne is hard because acne is not necessarily just pediatric, as you see it a lot in adults. Although there was this neat little research letter that I thought was really interesting. So you've got an adolescent boy who comes in with his mother, and his mother's really frustrated with the acne, but he's maybe not, doesn't seem to care, not really sure if he wants to do the medication or not. Is there any way you can motivate this teenager to use the medication that you want him to use? And this was, as I mentioned, a research letter that just came out in the JAD. And it was basically a survey where they had 80 teenagers, 18 and 19-year-olds with acne. And they were divided into getting 2 different survey questions that they were asked. They were asked, how likely are you to use this medication? And the questions were exactly the same. With 3 months of consistent use, an acne medication has an 80% chance of helping your skin become better. So that's something you would say possibly in the office. The medication is given via topical application every day and is associated with excessive dryness of the skin, peeling, and or increased sun sensitivity. And then they're asked, would you be willing, on a scale of 1 to 10, not willing to very willing, completely willing to use this medication? The second group actually had this one sentence put in, which is, this medication is the most popular among teenagers and young adults for the treatment of their acne. And by just adding that one sentence in, they found the bandwagon effect that teenagers really want to fit in. And so if they're told that teenagers find this is the most effective, that they find this the best benefit, they were more likely to want to use the medication than if they were just told by the doctor that's a good medication and here are the side effects. It was small, it was only 40 patients in each group, but you can see that there was a statistical significant difference in willingness to use it and willingness to think that it's going to work. And so this takes advantage of different aspects of social influence. So teenagers really want to fit in, and they really want to think that what they're doing is going to be effective. And so you've got, according to this paper, it talks about normative social influence, which is you're conforming because you want to fit in. So if your peers are doing it, you want to fit in. But you also believe that it might be right. So if the people that you believe know more about this are saying it's right, you're more likely to conform to be right. And so if you're saying that adolescents have found this to be really beneficial or they really like it, most teenagers are really happy with it, potentially you might influence your patient to use the medication more. It's similar to the way that adults do it. So some adults, masks are a great example of this, is depending on what your social group is, wearing something will make you conform or not conform. And then who you believe in terms of whether masks are going to be beneficial or not will affect whether you end up using a mask or not. This is taking that same effect to try to get patients to use medication for acne, because if your mom says it works, you're not going to believe it as much as your friends say it works, or possibly whoever's the new proactive spokesperson that you admire. And then going back into acne, this is just an opinion piece that I'm not sure if it'll be looked at. Going through journals, I think it's interesting to look at the editorials and the opinion pieces. And this is looking specifically at iPledge. This was, I think, pardon me, also in February in the JAMA. And it was looking at iPledge, and Dr. Frieden was on it, and she's on the American Academy of Dermatology's iPledge task force. So she wanted us to know that in terms of her author conflicts of interest. But basically what this article is saying is that iPledge is fairly broken in the sense that a lot of patients will say that they're abstinents and use abstinent as their form of birth control. And yet in a survey of women who said that they were abstinent, 19% actually reported being sexually active while on isotretinoin, even though their form was abstinence. And what this opinion piece is saying is that we should really frame OCP in terms of failure rates and not success rates. So say 10% of the women who are on the pill, when used in a typical fashion in a year, will get pregnant as a way of counseling. And then they suggested that instead of using male, female, that it should really become able to become pregnant and not able to become pregnant. And that'll help with some of the transgender issues. And really break it down into the simple biologic question, what you're trying to answer. Are you able to become pregnant or not? And then they also, this is before COVID, but they also encouraged more availability for the use of teledermatology in Storm Forward. And that's shown in this table in terms of the proposed changes that they had recommended. So currently you have to see a patient every month, whether you're on a long-acting contraceptive or not. And so this opinion piece is saying, if you have somebody who has an IUD in, do you really need to have them have a second form of birth control? And what they're saying is, if you have a long-acting contraceptive in, then maybe you don't need to see them every month. Potentially you could see them as much as every 3 months, and you could get a pregnancy test at initiation, and if you want to, every 3 months. But they're saying if you have, there's a huge difference between somebody who's taking the pill and somebody who's got a really effective form of contraception. And furthermore, if you're a patient who's not able to become pregnant, do you necessarily need to be seen every month? If you're on a stable dose and your labs have been stable, now that we know that labs are not as important as they used to be, or not as frequently needed as they used to be, do you really need to see a patient every month? And also, should you potentially have more teledermatology or store-and-forward dermatology as the way to deal with it? So it's an interesting question to sort of ponder in terms of what is the appropriate regulation for iPledge and for isotretinoin. And I have like 1 minute left, which is just to say I was trying to see this year, there's a lot of different social environmental dermatoses in pediatrics. And so if you look at these pictures, we've had the salt ice challenge before, where you put salt and ice and you try to see how much you can tolerate, which leads to burns. There's been the deodorant challenge, where you try to see how long you can tolerate an aerosolized deodorant on your skin, which leads to pretty thick, full thickness burns. And then there's been slime dermatoses, where you're having all these chemicals on your hands, which lead to dermatoses. So these are all these social environmental aspects. I was trying to see what potentially could be the one for this year. The only thing I could find was Hechodermandactyly associated with extensive computer gaming. Now that everybody is at home on the computers all day long, and we're really isolating in terms of not having as much social time, possibly this is something that you might be seeing more of. These were three adolescents who were spending an inordinate amount of time gaming, and they all developed Hechodermandactyly. They were all initially treated for arthritis. One got methotrexate, but they were biopsy confirmed to have Hechodermandactyly, and were able to discontinue it. They did try to treat a few of these with steroids, and it really did improve. Of the three, the only one that got better was the one who stopped gaming so much. The other two continued, and it didn't go away. So possibly something we might see more of, possibly with being secluded and having more gaming and computer time. We'll have to see. All right, thanks a lot.
Awesome, thank you so much. I see one question from Dr. Kidiobi about the concentration of the cantharidin. I don't know, Dr. Barrio, if you can speak to that or not, why the 0.7% was chosen, but I don't know if there are any other talks before we let people, any other questions before we let people head out, because we are at the 11.
I'm sorry that it's 11. You know, I think it's probably historical. I don't have that information. I wasn't, like I said, I wasn't involved in that study, but I think it's historical just on what's been used before. I don't really know how they got to that number.
Hi, this is Sue. I think that it was very unnerving to see the picture of the hand without a glove on it, holding the cantharidin. That wouldn't be me.
Oh, great. Thank you so much for the residents and tremendous work and putting that together. And thank you, Dr. Barrio, for a great talk. All right. Dr. Barbar, was there anything else? No, I think we're done.
No, thank you. That was great. Thank you, Dr. Hightower. Thank you, Dr. Barrio, and the residents. Great cases and presentation.